why is it then testosterone is so important for all the things you just mentioned, like metabolic disease? I've covered with Dr. Ovadia, where, like obesity, high triglycerides, high blood pressure, these are all, insulin resistance. These are all factors that lead to metabolic syndrome. So is it almost safe to say that folks that are experiencing metabolic syndrome should get their testosterone levels checked, obviously the men, because this is just like a big flashing alarm bell that you've got something wrong within your hormonal framework, so your endocrine system. If you could expand on that, I'm just curious to know. I think if folks would like to know too, like how does testosterone drive all these things? And if you have low testosterone, how does it impact you on all those factors?
Yeah, so I think that's a really, really good question about how that impacts the metabolic effects that we see. Should we screen every man with metabolic syndrome? It probably depends on who you ask. If you ask me or those of us that are specialists in this, I think we would lean the answer towards yes. Why would we want to miss that in them? But if we go to guidelines, which is what we're meant to base our practice patterns on, based on evidence-based medicine, if we turn to the endocrine society guidelines, the recommendation is actually not to test testosterone levels in men that are asymptomatic, that don't have symptoms. Now, my personal view is that if a patient has a really low testosterone and it's going to impact bone density bad way, blood sugar regulation bad way, metabolic syndrome, and survivorship, whether he has symptoms or not, I would want to treat that man. So again, not all of our practice patterns perfectly fit guideline statements, but we try to stay in our lane a little bit to make sure that we're not just all over the place in practice patterns as well. In my opinion, if I've got a patient that I'm suspicious of because of other health risks, I would test them. Now, how that impacts things, a lot of it has to do with body composition. I think the more and more we learn, and again, there's metabolic regulation that testosterone is important for, but the more and more we learn is that obesity is this major epidemic, not just in the United States, but worldwide. Childhood obesity now. What does obesity do from a testosterone standpoint? It causes a vicious cycle. So when there's obesity, fat cells convert testosterone into a form of estrogen, estradiol. So the more fat we put on, the more testosterone we convert to estrogen. Your estrogen goes up, your testosterone goes down, which is pretty much bad for everything. And then on top of that, where do men tend to put fat on? The lower abdomen, upper pelvis, and we're actually increasing testicular temperatures in that area. And again, if you look anatomically, men are basically built with the testicles outside of the body down the scrotum because they function better at a 2 degrees centigrade cooler temperature than the core body temperature. And so when we're increasing fat content down there, that's going to increase testicular temperatures. So we have multiple mechanisms by which obesity is impacting our cellular function, and then it's a vicious cycle. Testosterone drops, it's harder to burn fat. We put more fat on. Estrogen rises, that makes us put more fat on. So we have to break this cycle. We have to get testosterone regulated. We have to get estrogen optimized, allow that body composition to improve. There are even some men that may have borderline testosterone levels where we can make these lifestyle changes and they're able to regulate their testosterone optimally. Now, the truth is that's really difficult just because of the way lifestyles are these days. Diets, how we live, number one, but number two, because it is really hard to burn fat with a low testosterone. So sometimes we'll use treatments, sometimes rather than replacement, we'll use cellular stimulating treatments, Clomid, HCG, other ways like the nasal gel and the testo that are not as suppressive to the system, and will allow that man to be treated to normalized levels. And that helps with the improvement of body composition. And then we may stop that treatment and see now that we burn fat and we allowed the body to maintain muscle, which of course they've got to do the work. They've got to do the diet and the exercise. They can't sit on the couch and just take they're just,
Oh,
right? You know that.
so you mean I can't just take testosterone therapy and just sit down and do
Right.
podcasts all day?
But the motivation's
Shit.
not there either, though, right? I mean, this has been shown in study after study that when testosterone is deficient, that I should go to the gym, but I just can't get off my couch. That is a really interesting factor that we see change when testosterone is normalized, and men are getting more motivated to get into the gym and work out and do those things. So we're able to reverse that vicious cycle, and sometimes we can just stop treatments, and if we get enough optimization of body content, we might even be able to keep that man off treatment.
Okay, that was going to be my next question, because from what I understood, as soon as you start, that's it. You're on that slow train for the rest of your life.
So that's
TRT. But
kind of
there is a way to not potentially be always treating yourself with TRT if you're able to get, let's say, body fat down, motivation goes up. Now you no longer have that vicious feedback loop of being obese or having too much body fat, producing too much estradiol, which demotivates you and stops you from burning body fat, which stops you from having a higher testosterone. So if I understood that correctly, there is a way forward that doesn't require constant
so
supplementation.
first and foremost, we would always encourage lifestyle modification as a first step rather than medication, right? So
Right, right,
diet,
right.
exercise. If a patient is motivated, that person is willing to do that. But again, it's really hard to do that when your testosterone is low. You just that something cerebrally is not that motivation center is not doing what it's supposed to with a testosterone deficiency. So that's why I mentioned kind of these off-label treatments rather than direct testosterone replacement, like Clomid and HCG, which are ways of stimulating cells to make testosterone. Where when we stop them and when we use them, we're not suppressing the testicle cells. That's why we think of testosterone as long term, is because we're going to suppress that system. And then that could commit men to long term treatment if they're on it for long periods. Now, if you're on testosterone for 3 months, 6 months, a year, and I take you off it, it's very likely you're going to bounce back to where you would be on your naturally declining curve. If you're on it for years and years, then those cells may not wake up and start working as well. But that's another great place where I think, I've done, as you know, a lot of research on the intranasal gel and the testo, and I think that's a really nice use for that because that is one that is very minimally suppressive. The signaling center under the brain that sends signals testicles to work, those signals on any other form of testosterone replacement bottom out to zero. Testicles quit working. We take over function with the drug. With the nasal gel, because it's short acting and trying to mimic our physiology, it allows for the overwhelming majority, not 100%, but nearly, men to continue that pulsatile signaling of hormones to the testicles to keep them working. So we see that not only can most men maintain spermatogenesis and fertility, but they can maintain their own testosterone production. So I think of that drug like where other testosterone replacements, we're giving it to them, we're stopping their system and taking over that function. This drug is allowing their system to work and giving them a little extra on top of it. And then we talk about medicines like Clomid or HCG that are just pushing the whole system to work harder, but may not get as strong of a symptomatic response as we do in testosterone replacement. So if our goal is in a guy who maybe has low to borderline low levels, not extremely low levels, and has some body composition room to improve, there's some room to burn fat and put on muscle, he may be a great candidate for one of these treatments temporarily to see can we improve body composition, stop it, reassess and see now have we normalized or no is cellular function such that we're going to be treating long term.
That makes a lot of sense. I think I'm the perfect candidate right now.
Well, you're lean, right? I mean,
Like,
you got a good build, you're lean, so I think that's kind of a good candidate for this. Absolutely.